Welcome, everyone, to our annual summit here at the National Hypertension Control Roundtable. My name is Jenny Bogard, and I am the Executive Director for the Roundtable, and I'm so delighted to have our guest speakers today and our steering committee members and everyone who has supported our work tremendously over the last year and beyond. But before I get into it, I am going to pass it over to Dr. Jaime Murillo, who is one of our co-chairs. Jaime, the floor is yours.
Yeah, thank you, Jenny. Welcome everyone again, and thank you for spending this time with us today. We're very excited about the annual summit, very excited about the topic. As you can see, the time is now closing the gap in disparities, quality payment, and implementation. As you can see, it aligns perfectly well with our mission of controlling blood pressure with equity in the United States, with the support of each one of you and the number of organizations that we are lucky to have as part of the roundtable. This roundtable is also honoring the memory of Sal Lucido, who many of you many of us actually had the privilege of meeting. He was instrumental in the foundation and founding the National Hypertension Control Roundtable. His name is actually, we're honoring him by attaching his name to the Hero Awards that will be also given out and that we continue to give out every year, highlighting the many accomplishments that you and your teams do to control blood pressure. We also privileged to have become a consortium that arguably represents pretty much every stakeholder within the healthcare space when it comes to blood pressure control. So we feel like we are in a very privileged position, and that we are the right venue for us to have this kind of conversation. So we have an incredible agenda today, and I want to make sure that we get to it. So I'm not going to speak too much because you'll have an opportunity to see the introduction to the incredible speakers that we have. So I'm going to now pass it on. Thank you again, and pass it on to Jenny.
Thank you, Jaime, and thank you so much for your leadership at the Roundtable. So before we dive into our distinguished speakers today, I just want to give a very brief overview of the Roundtable and who we are for the few of you who may not know exactly what we do. So we are a coalition of voluntary members who are all working towards improving hypertension control in the communities that we serve. Our mission and vision is really to eliminate disparities in hypertension through our partnerships, evidence, innovation, and dialogue. What gets me so excited is this vision statement where we really are working to extending healthy life for everyone. And as you can see in our values, health equity is at the core of everything we do and all the work that we do with our partners. So our key initiatives, for those who aren't as familiar, in addition to the annual summit where you are all sitting today, we host a series of fireside chats throughout the year where we invite speakers to talk about hot topics within hypertension control. In fact, we are going to have our next fireside chat either later this month or early December, where we're going to be looking at an assessment done on digital health technologies with hypertension control. So look for more information for that, but we are so excited to kick off this year's fireside chat series as well. As many of you know, we do have a payer task force where we work closely with our payers who are members of the Roundtable, and we were able to present at the America Health Insurance Plans annual conference earlier this year in June, where I sat on a stage with some of my payers, and we really talked about the value of collective work among different payers. We also create resources and tools for purchasers and health plans as they're considering implementing better hypertension control programs. So if you're interested in hearing about more of what the work that we do with that task force, I invite you to reach out to me as well. We just launched a team-based care task force where we're working with pharmacists, community health workers, nurse practitioners, and all allied healthcare professionals who are part of the hypertension control team. We are so excited to kick that off, and we have a wonderful group of individuals who are focusing on how to bridge the gaps on pay parity with pharmacists providing care, how to increase awareness of the value of allied healthcare professionals as part of the overall team. We just launched a maternal hypertension control initiative where we kicked it off with a fireside chat earlier this year. And then we invited key stakeholders to an in-person summit in May where we talked about how we can do better when it comes to hypertension control with pregnant people. We worked very closely with Million Hearts, and this was aligned perfectly with their change package that they just published earlier this year. We're continuing to build out this initiative, so if anyone is working in maternal hypertension, I invite you to reach out to me. I am so excited to share that we have a meeting with the FDA in early December to talk about some of the requirements to get validated devices into pregnant people's hands. So more to come on that. We're also going to be hosting another in-person summit in May of next year, focusing on maternal hypertension. So we're so excited to build out this initiative and invite anyone out there today who is working in this space to reach out to us. In addition to all of those initiatives and verticals within the roundtable itself, we're always looking to recruit members. So if you have an organization that is doing some wonderful work or an individual that's doing wonderful work, please feel free to connect me to them. I'm always having conversations with organizations to learn more about all the amazing work that you are all doing on the ground and how we at the roundtable can help lift that up. We also work with a lot of different partners. As you know, we have, as Jaime mentioned, it's a multi-sectoral collaboration. So we have payers, you'll see the nice graphic on the slide today. We have purchasers, policymakers, product manufacturers. We work very closely with Amran and Jim Lee. So anybody who's in this space is invited to sit at this table with us. And finally, we send out those quarterly newsletters to everyone that has wonderful resources from all of you, our members. So we're continuing to push out the great work that you are all doing. So if you have any resources you would like us to share or any upcoming webinars, please reach out to us. We're happy to include that in our newsletters. So you heard from Jaime, but just a little reminder that these are the two co-chairs that are fearlessly leading us as at the roundtable. Jaime is ending his 2-year term. He's rolling off at the end of this year, but Yvonne is going to be with us next year as well. And I'm so incredibly grateful for all of the time that they have given to us at the roundtable, in addition to their expertise. These are our steering committee members that have come back to us. So as you might know, we have an open call for applications earlier this year. And these are the steering committee members that have reapplied and have recommitted to the roundtable for the next term, which is 2025 to 2027. So thank you so much to all of you who are returning, and a big welcome to our new steering committee members who are joining us for the first time in a leadership position. As you see, we are constantly trying to identify different perspectives who can come to the table in a leadership position to help steer the roundtable to make it even stronger and better every day. So thank you to the new steering committee members. Welcome. We are so excited for you to join us. Here is the full list of our steering committee members for the 2025-2027 term. Their information will be on our website by the end of this calendar year. So again, if you see someone up on the list that you recognize, feel free to reach out to them and congratulate them, but we are so excited to work with them. And with that, I will announce our new co-chair who will be joining Yvonne next year and who will sit as the co-chair for 2025 to 2027. This individual has been a stellar supporter of the roundtable. Not only is he an expert in his own right and has many, many different things that he's working on in his leadership position at his organization, but he has always shown up for us. And we are so incredibly excited to announce that Steve Chen will be joining Yvonne as our next co-chair. He has been an amazing, amazing, amazing supporter. So please feel free to reach out to him and congratulate him. But we are so excited to have him join us as a co-chair for the next 2 years. So with that, I'm going to pass it over to Yvonne, our other co-chair, to introduce our next speaker. Yvonne, the floor is yours.
Great. Thank you so much, Jenny. Good morning, good afternoon to all of you. It's such an honor to be here today, and I'm equally honored to introduce a dear colleague and friend, Dr. Joshua Joseph. His full bio is in the program book, but I'll tell you a little bit about Dr. Joseph. He's an associate professor at the Ohio State University Wexner Medical Center. He's also the founder and the medical director of the OSU WMC Healthy Community Center. In fact, he is joining us now from the community medical center. So Dr. Joseph is globally recognized as an expert in advancing health equity, and he does this through partnerships with industry, with organizations, with government. So really, you're in for a treat. I want to thank Dr. Joseph for taking time to be here today. And so without further ado, let's invite Dr. Joseph with a virtual round of applause. Dr. Joseph.
Thank you so much, Dr. Yvonne Commodore Mensah. It's an absolute pleasure to be here. Thank you, Jenny, Janet, Jaime, the whole team who is behind all the great work that is getting done, not only locally, but around the country. And so truly appreciative. Let me go ahead and share my screen, and then we will go. So hopefully that is displaying. And so today, on behalf of my entire team here at Ohio State, as well as the Government Resource Center at the state of Ohio, I present the Achieving Cardiovascular Equity Project. Here are some of the financial disclosures. And so why hypertension? Well, this is my grandmother. She was a school teacher down in Louisiana. And she came up to Ohio when I was a young boy. That's actually me in the bottom left there. I'm a Buckeye. I don't know why they got me a blue car, because up our way it's tough to have blue. But I wear red these days. And my grandmother had two things. She had hypertension and she had diabetes. And she taught me my ABCs and my 1, 2, 3s. But I also remember the first day she clutched her chest. Now, all of you know she was having a heart attack. Went to the local hospital. Got a procedure done there at the hospital. They opened up her blood vessel, and then she came home. But a few months later, she went to the hospital and never came back home. And for me, that really tailored my career, right? I am an endocrinologist by training. I treat diabetes and do a lot of work at the intersection of diabetes and cardiovascular disease. So that's the why. It's really for all those folks who want to lead longer, healthier lives, really in alignment with the mission that you just saw 2 slides ago. And so we'll talk about some approaches to advancing health equity and really give some real world examples of how we are achieving cardiovascular health equity. And we're tailing that down today to the ACE project. And so why is this work important? And here I'm preaching to the choir a bit, right? Y'all know that hypertension control rates are higher in some communities versus others. You know that Black populations in the United States have lower hypertension control rates. You know that hypertension is responsible for 1 in 3 cardiovascular events in this country, and about 43% of heart disease in Black populations. And you know, or you may not know, that in Ohio, the prevalence of stroke is about 4% and heart disease is about 7%. And it's so that, Ohio adults really have a higher prevalence compared to other portions of the United States. We kind of, particularly in the southeastern part of Ohio, we're still in kind of the Appalachia community. So we have both urban communities here, suburban communities here, and rural communities here in Ohio. And so we know that heart disease in Ohio claimed over 30,000 lives in 2022. We have the 12th highest death rate from heart disease in the United States. In Ohio, when we look at those potential years of life lost from heart disease, it's about 10.7 in white populations compared to 19.3 in Black populations, really speaking to that disparity and the importance of equitable approaches to advance blood pressure management. And when we look at this nationally, and once again, preaching to the choir a bit, but when we look at guidelines, really irrespective of guideline, whether we're using, kind of 130 over 80 or 140 over 90, there exists disparities with Black populations having the the highest prevalence of hypertension in the United States, across the different guidelines that exist. And this is some great work from my good buddy, Paul Muntner. And so when we think about health equity, we know that there are, equitable approaches, and then there are quality-based approaches. When we look on the left side of the screen, and this is from the Robert Wood Johnson Foundation, you see that everyone gets the same bike, regardless if it's needed or whether it's right for them, right? And you see that can cause some difficulties, right, for the person at the top, as well as at the person at the bottom of this slide. I always like to point out that for the person in the middle, that bike works really well, right? So equality-based approaches work for some populations really, really well. And that can actually lead to another term that we talk about in this type of work, intervention-generated inequalities, where individuals who that bike works really well for, they're going to go faster and they're going to go further than those other populations. When we look on the right side of this slide, we think about equity. This is where everyone gets what they need, understanding the barriers, circumstances, and conditions. And you see that all of the modes of transportation there work for all the individuals in the slide on the right side. And so with that as a background, I am PI for the Accelerate Research Group, Advancing Cardiometabolic Health Equity through Translational Research. We have 4 pillars: epidemiology, quality improvement, health system to community interventions, and community-based participatory research. Our roof is health equity, and our foundation is academic, community, government, industry partnerships. And we do all this within the T0 to T4 scientific realm as well, where we do work, translation out to community, all the way back to some very basic mechanistic work where in our clinical trials, we will collect things like blood and hair and stool to be able to look at gut microbiome and kind of what's underlying the improvements that we see. We also believe in the socio-ecological model, where we really believe in engaging at the individual, interpersonal, organizational, community, and public policy levels. People often ask, why do you engage at all these levels? And we think that for equitable approaches, we have to be multimodal and multi-pronged, and it really takes kind of engaging across the various levels to do that. And we focus on centering on equity with community-engaged, diverse teams. And this is the team of folks that I get to work with every day, and truly honored to be able to work with them. And so today we're talking about quality improvement, and we're going to talk about the Achieving Cardiovascular Equity Primary Care Hypertension Quality Improvement Project. And on the line today, I know they're out there in the audience. I saw Wendy Grosnick and Sarah May, Allison Erlins and Evelyn Corshi are 2 other team members on this project. And then you can see the clinical advisors, including myself, Dr. Williams and Dr. Adesanya. This was funded by the Ohio Department of Health. And so when we think about this QI project, the focus was on improving blood pressure control with an emphasis on advancing health equity in Black patients. So together, we worked to identify patients with undiagnosed hypertension, improve management of adults with hypertension, and address those critical social determinants of health among this patient population. And when we think about those social determinants of health, those factors that impact the individuals where they live, work, pray, and play, we know that some communities, as is the community on the right, you've got, wonderful trees there, places where you can be physically active, plenty of grocery stores, etc. And then other communities are more like communities on the right side of the screen, where there may be more environmental sources of, let's say, pollution, more difficult to be physically active, and just have a tougher environment in which to live. And these things we know impacts individuals in multiple ways. But one of the ways that they impact individuals is with hypertension, with higher levels of blood pressure, greater hypertension prevalence, ultimately leading to cardiovascular disease. And so in the Achieving Cardiovascular Health Equity Improvement Project, We had some key drivers. Once again, those were identifying undiagnosed hypertension, also focusing on treatment algorithms and follow-up visits. And I'll talk more about that. And then establishing community connections to address the social determinants of health. Some of our main strategies were adoption and utilization of EHR data, simplified treatment algorithms, facilitating self-monitored blood pressure, engagement of non-physician team members, including MAs and nurses and other team staff, patient self-efficacy, accurate evidence-based techniques. And y'all have all gone to the doctor when you run into the office, you're coming out the car, you've had 3 coffees, your bladder is full, they plop you up on the counter and look, hey, let's check your blood pressure, right? So we're really focused on how do we do this correctly, right? Outreach and scheduling visits, referral processes to community resources, and reducing implicit biases. And our outcome here was hypertension control. And the state of Ohio defined that with the less than 140 over less than 90 parameters. The expectations for our sites, and we had close to over 20 sites in this project. I'm sorry, 11 sites at this project, is that we want them to implement clinical change packages and patient resources. So we tested toolkits and provided feedback throughout the collaborative. We worked with QI coaches for the sites. We implemented proper BP techniques, and I already mentioned the self-monitor blood pressure. And then we tried to have patients who, had uncontrolled hypertension to be seen within 35 days for a second appointment. We also worked on establishing referral networks for those community connections. We engaged in data feedback, so identified patients with hypertension in the EHR and brought them in for care. Reviewed data feedback with the teams, and received support and QI coaching to effectively implement the test of change, which I'm going to talk about. And then some of the benefits to these practices included potentially improved patient outcomes, the data feedback, and potential to improve some of the CMS and NQF outcomes as well. And so in our project, when you think about equity versus equality, we had some very specific callouts, both on the provider side and on the patient-facing material side. So on the provider side, we talked about implicit biases and how they can lead to clinical inertia. We use peer review office visits, can help overcome clinical inertia and reduce disparities, and really emphasize that the ability to communicate shared experiences and develop common grounds to develop relationships with patients is a key to blood pressure management. We looked at some of these patient factors, including medication being kind of multifactorial and modifiable. So kind of really building confidence in patients' ability to take their prescribed medications to improve control. And then the use of single pill antihypertensive combinations as one method that may be particularly beneficial in Black patients based on literature that we found. Hypertension beliefs, we found that Black patients often attributed their hypertension to family history, and there's a potential there for decreased medication adherence. So really the full education around what blood pressure and hypertension are is critically important. And a large percentage of patients rated stress at home as a cause for their hypertension. And then to the need to improve self-efficacy. And so really trying to build self-efficacy within the patients that these practice sites were seeing. And then lastly, the community connection, which I've already kind of spoken about. On the right side of the screen, ensuring that, we are explaining what hypertension is, right? And so this is one of the patient-facing materials that they were printing out and giving to patients that really lists, what can patients do and why they should do these various pieces. And they found this to be effective when they were working with patients in their clinic sites. We also, discussed how Black patients could have high blood pressure earlier in life. It may be more difficult to control and often requires medication. And then we educated all of them on the DASH diet, which, I don't have to explain the DASH diet here, but as you know, with those DASH diet studies, the blood pressure lowering effect is even greater in some Black populations with the DASH diet. So really felt that was a key dietary piece to our quality improvement project. So when we think about building confidence in medication adherence, one of the most prominent factors that crossed all barriers was medical mistrust, right? And so we really had to kind of work on the medical mistrust piece by, once again, establishing that common ground, establishing relationships with patients to allow them to have these crucial conversations related to blood pressure. And this comes from some of the work of Greg Hall up in Cleveland, Ohio. Other factors in building confidence in medication adherence are socioeconomic, healthcare system related factors, concomitant illnesses, therapy related factors. So, kind of multiple medications, pill burden, et cetera. And then some of those patient related factors as well. And then some of the collaborative approaches that have deemed successful are some of the approaches from the Million Hearts Campaign, the National Forum, Duke Adherence Alliance, and the National Consumer League, as well as the Enhanced Adherence Strategic Initiative. So we're able to use some of these strategies within the QI project to build in that confidence on medication adherence. And so on the provider factor side, we really focused on once daily medications, combination medications. So, on formularies here in Ohio, we have both dual therapy and triple therapy antihypertensives that are available even on our Medicaid formularies here in Ohio. Medication cost is something that was discussed with patients and ensuring that we're doing all we can to consider that. 90-day refills versus 30-day refills, education to improve hypertension-related knowledge, and then empathic, collaborative provider communication and shared decision-making. We had sessions on all of those with our providers. In terms of the hypertension treatment algorithms, we use two. The updated treatment algorithm, which recommended, for use in the SPRINT trial, which really starts with chlorthalidone rather than hydrochlorothiazide as the preferred thiazide-like diuretic for initial therapy. And then we also use the classic treatment algorithm that, lots of great data out of Kaiser Health, Kaiser Permanente, as well as Better Health Partnership up in Cleveland, which starts with hydrochlorothiazide. And so it's really that chlorthalidone versus hydrochlorothiazide. And we let them use either of those algorithmic approaches, but we really emphasize the use of algorithms. And that's something that really came from this project. Many of the providers were not using algorithms to start this project. And when we've done kind of focus groups and scans of other practices around the state, we see something similar where there's a large opportunity to use algorithms to improve hypertension control. Some of the patient and clinical factors were self-efficacy and self-confidence, the addressing attribution of hypertension to family history and stress, and kind of discussing that what is hypertension piece. And then really talking about mental health and wellness, because that came up in many of our practice sites as well. And then lastly, the community factors. So the importance of, not only addressing those upstream social determinants of health, but addressing those individual non-medical health related social needs, right? The individual experience of those social determinants of health, and then really working on building trust in healthcare systems and practices. We had action period calls on a monthly basis, and we used a modified version of the IHI Breakthrough Series model for QI, where we started with selecting the topic, recruiting the practices, developing our framework and changes, enrolling the participants. And then we had these learning sessions followed by, PDSA cycles and another learning session followed by a PDSA cycle, et cetera. And then kind of multiple supports for the practices through our Government Resource Center team that was led by Allison Lorenz. When we think about that coaching, discussions occurred around setting goals, small tests of change using PDSA cycles, refining tests prior to system implementation, and then QI coaches held teams accountable. And we also did site-level data review, which include both site-specific and aggregate data, track progress to goals, and then review disparities. The site-specific missed opportunity list, this is where we're able to engage with those individuals hidden in plain sight. I'm sure you're very well aware of Haley Wall and all the great work at the Million Hearts that they do. We use that similar approach there to identify those individuals with undiagnosed hypertension. And they got a report of those individuals on a monthly basis that included name, blood pressure reading, date of last visit, and race and ethnicity. So what were some of the successes from the ACE project? So from baseline to the implementation period to sustainment, we went from 66% control up to 72%, and then ultimately to 74%, so about an 8% absolute improvement in blood pressure control. We had a reduction in disparities at 9 of our 11 sites. Saw an improvement in hypertension control for Black patients. It's actually a reduction in the disparity. And then other findings was that there was inconsistent social determinants of health screening. So we're working to build out those screenings and then challenges related to connecting with community resources. And so those are things that we are still working on in our current project that we have ongoing. And this shows the data for the white, Black, and Hispanic populations. And you can see that there was an 11-point improvement in Black populations from 60 to 71, an 8-point improvement in Hispanic populations from 66 to 74, and a 5-point improvement in non-Hispanic white populations. So really kind of closing that equity gap that we see with hypertension control, but also improving blood pressure in all racial and ethnic groups. So some lessons learned from our QI efforts were the consistent use of a treatment algorithm is really key. Visual reminders are another key at the practice sites. Multidisciplinary teams and communication are important, and prompt patient follow-up is another important key. So building on the successes, some of the future work is now we have launched the ACE Plus project, with county health departments and 7 satellite clinics, 2 residency clinics, 2 med-peds clinics, and 1 independent provider. And as you can see, this is really across the state of Ohio. And in this project, the only difference that we're building in on all the successes, but we're also adding cholesterol to this project. So we're thinking about lipid management as well. And then we're building out more resources around addressing social needs. And I'll talk about that here in a second. Patient-provider engagement, and then those QI processes that we know are successful. So use of updated treatment algorithms, rapid follow-up care, and then addressing those patient factors are all key drivers for this project. And, differences though, we're reviewing the patient's lipid panel, looking at the ASCVD risk scores, assessing for statin use, and then identifying the need for statin intensification, as well as doing the blood pressure components in this project. And then when we think about that community connection, we are now working towards partnering with closed loop referral systems to encourage community connections. In Ohio, we have a system called Unite Ohio, which is an electronic referral network. So we're trying to onboard these practices to the Unite Ohio platform so that they do the screen, that identify the areas of need, and they get folks connected with the resources. Some of our practices are interested in that. Others have kind of more in-house resources or referrals that they are doing. And so in conclusion, some of the keys here are really targeting the inequity. If you're really looking to advance health equity, you have to target the inequity. Focus and persistence. This work is not easy, right? Leadership of projects is not easy. Being a practicing provider in a clinic is not easy. And being someone living with hypertension is not easy, right? And so focus and persistence are really key. Evidence-based programs, when possible, please utilize them. And the example that I give here is that we know these treatment algorithms work. We got to get folks to utilize the treatment algorithms, as much as they can. Academic, community, government, industry partnerships, and team science personally are near and dear to my heart, and I think are really key to the work that we do. With that, I will say thank you and pass it back to the conference organizers.
Thanks, Dr. Joseph. I have a quick question that came in about the work. Somebody asked, can you define peer review office visits?
Yeah, so that's where you actually look at the office visit and just see what happens in that office visit and then give feedback, right? So somebody who has expertise in hypertension is able to look at that office visit. Okay, this was, the parameters that were set for the visit. The person was on 2 medications, their blood pressure was this, et cetera, et cetera. And then kind of giving that case-based feedback.
And then have you used community health workers in your project?
Yeah, so we don't have community health workers as part of the project, but we have resources to get them connected with agencies that have community health workers. So here in Ohio, we have now 10 agencies across the state. Here in Central Ohio, they're called Health Impact Ohio, and they work with community care agencies. The community care agencies house the community health workers. And what's great about it is that as they are actually addressing social needs, there's a payment that comes back from the state. So we actually have a sustainable model for community health workers here in Ohio, which has been a huge benefit to many of the projects that we've done. And I work with them on literally 90% of my projects.
That's amazing. We're working to engage community health workers as well as part of that team-based task force that we have at the Roundtable. So I have a general question for you. What has been your biggest aha moment throughout this project?
Yeah, I would go back to a couple things. One is the treatment guidelines. I just assume that, there are hundreds of folks that are working on these treatment guidelines, right? They're all evidence-based. You got grade A, grade B, grade C, all these great recommendations. I just assume that everyone used them. All right. And that was just an incorrect assumption. Right. And that was a part where I kind of took a step back and said, how do we really engage with folks? And then with providers on that. The second one, though, I would say is more on the patient side. And, I think we assume that people understand what blood pressure is, what hypertension is, why they should control it even. I think, okay, it's on the TV, it's on the news, this is why you should do it. When I connect and engage with lay people in our community-based interventions, many folks can't tell you what a normal blood pressure is, yet alone what a high blood pressure is, right? Many folks don't understand why they need to take a pill for the blood pressure. I had a guy 2 weeks ago had a blood pressure of 210 over 105 and said, well, it's okay, Dr. Joseph, I'm going to change my diet. Right. And we all know on this call, the max you're going to get from dietary change, about 8 to 12 points on max. That's with DASH. Right. And so, explaining that, engaging with people, we have to break down the walls of the healthcare system and the public health system to truly engage with people where they are to perform this education. Because once they understand, the aha light bulb goes on. Right. And then all of a sudden, medication adherence is not an issue anymore. Right. Issues around self-efficacy. All of a sudden you see it building within them. Right. And then boom, you're done. Right. They'll go into the doctor and say, hey, I'm on 2 meds, but my blood pressure is 145 over 83. I think I need a third medication. Right. Because that's what the evidence says. Right. And so how do you get to that point? You got to provide that education, but we got to do it in communities, in places where people live, in their own environments.
And I have one more question for you. I hope you can answer. I'm so sorry. So I know, so for everybody who doesn't know, he's in clinic right now and has patients in 2 minutes. So thank you so much. Okay.
Yeah.
So another question came, what was your experience with getting clinicians to prescribe combination therapy?
Yeah, that actually went really well. So what we did was we showed we have a unified formulary in Ohio. So we had the unified Medicaid formulary. Then we had the formularies from the different insurances available. And once folks saw that dual therapy was really covered, right, and triple therapy even was covered, we had 2 medications, triple therapy covered on most of the formularies. That was really not an issue. And I'll tell you that has a dramatic impact. If it's one pill, but it's got 6 different medications on, nobody cares, right? It's one pill, right? And we've seen this in all the national work, right? I'm not saying anything new here, even when we've tried combinations with other therapies, right? All these approaches, whether they've been done in the US or now in India and other places around the world, are showing a benefit to these combination therapies. How do we get this thing into one pill, one vitamin that you take in the morning? You wake up, you take your vitamin, you're done for the day, right? No one's going to give you a problem about that. But when you have 12 pills that you got to take, that's really hard. That's really hard for folks, right? Is how I would answer that question.
Awesome. Well, you're getting a lot of wonderful comments in the chat box. I don't know if you can see it on your end, but everyone is so appreciative of your presentation. Can we share your slides?
Yes.
Awesome. Thank you for that. I will let you go back to your patients now, but thank you so much for this wonderful presentation and all of the work that you're doing. And I hope that we can continue our conversation with the roundtable. So thank you for your work, Dr. Joseph.
Thank you so much. And thanks for the opportunity. And thanks for all the great work that the Roundtable does, that the CDC does. It's just great and truly appreciative to be here today. Thank you.
Have a great afternoon. Thank you. That was a wonderful presentation to kick us off today. And again, we'll be able to share his slides, so we'll send that out after the summit. But thank you to Dr. Joseph again. I know he jumped off, especially because he's in the middle of clinic. He's actually at a center right now in a community where he's going to be seeing patients. So with that, I'm going to introduce our next presenter, if I can find my mouse. Okay, so with that, I'm going to invite Karen Maddox to come join us on our virtual stage. She is the co-director at the Center for Advancing Health Services, Policies, and Economics Research, and associate professor at Washington University School of Medicine. And before she begins her presentation, I just want to acknowledge that even though Dr. Joseph had to jump off, Karen will be joining Janet Wright and Dana on our next, after Dana presents, on a panel presentation for a wonderful discussion to end our summit. So I will give you control, Karen, of the slides, and you should be able to go.
Great. Thank you so much for the kind invitation to have me as part of this fantastic event. That was a wonderful presentation and definitely a tough act to follow. I'm going to go a little more epi here and provide a little bit of an overview of how the rural story might play as we think specifically about hypertension. So I'll just show you my outline here so you know where we're going. We're going to start by talking about what is rural, talk about the main causes of rural health inequities in hypertension and in cardiovascular health more broadly, and then talk about some opportunities for change and conclusions. And as Jenny noted, I very much look forward to a discussion at the end. Okay, so what is rural? Well, it depends who you ask, depending on whether you look at the Census Bureau, the Office of Management and Budget, the Economic Research Service, the USDA, any of, depends how granular you want to get, but it's a lot of folks. So it's somewhere between 46 and 66 million people, or 15 to 20% of the US population. Obviously a much bigger landmass proportion, but people-wise, we're looking at about 1 in 5 folks in the US living in a rural area. Now, interestingly, rural health inequities are a pretty recent phenomenon. So if you look back to the mid-1980s, rural and urban death rates were similar. And I think what you can see on this slide is that improvements in deaths per 100,000, basically population level mortality, have continued in urban areas, and that's the blue line in this slide, whereas the improvement in rural counties really dropped off. And so now we have about a 20% disparity in population level mortality between urban and rural areas, and these trends have continued to widen in more recent years. Now, we know that hypertension is a big part of that. So hypertension is highest in rural areas, especially among Black individuals. So on the left, you can just see hypertension among US adults, total about 28.7%, but 32.6% in the rural areas, which is higher than the both large and sort of medium metropolitan statistical areas. And then on the right, you can see the degree to which this actually contributes to really profound racial inequities in hypertension. And you can see the blue solid line there is Black rural adults. And this is deaths attributable to hypertension. And you can see just a markedly higher rate, both in Black rural and Black urban individuals. But again, that gap between the red and the blue lines on top representing the additional gap for Black individuals in rural areas. And consequently, we know that hypertension and obviously cardiovascular disease and stroke that follow from those are major drivers of rural mortality. And that's particularly true in minoritized communities. So if you look at this map, this is age standardized mortality rate from cardiovascular disease, but you could superimpose actually most health conditions onto this same map and find similar patterns. It's really the intersection of rurality, of the disinvestment from racism, and from deep poverty in some of these areas, particularly in sort of the Mid-South, where we see really just profoundly higher rates of cardiovascular disease, stroke, and hypertension. So why? Well, there's a number of reasons: traditional risk factors, social determinants, and then sort of the structural parts: healthcare, insurance, and access, quality, and capacity. And so I'll go through some of these in turn. So we know that obesity is markedly higher now in rural areas, and this did not used to be the case. I think people still sort of have the idea of like the healthy rural farmer, right? People who are sort of out being active and not sitting at desks all day, but it turns out that's not the economy anymore. And so we've actually seen a marked rise in obesity that has now overtaken in rural populations. And obviously we know that obesity is linked to hypertension. So you can see here in regions across the country, pretty consistent higher rates of obesity among non-metropolitan than metropolitan individuals. We know that behavioral factors contribute to worse health in rural areas, and these are all at least linked to hypertension and certainly to the sort of translation from hypertension into stroke and cardiovascular disease. So on the left, you can see a graph that looks at mental health issues. So this is trends in suicide by level of urbanization, with really just markedly higher suicide rates in rural communities, reflecting obviously a host of mental health issues and a lack of access to care. Smoking rates twice as high in rural versus urban areas. And of course, the opioid epidemic and drug overdose death rates much higher in rural than urban areas, though urban areas have been catching up in recent years. So really a host of broader contextual factors in the mental health space that contribute both to hypertension and then to health more broadly. We also know that poverty is a major risk factor for poor health outcomes. And in every age group, people in rural areas are now markedly more likely to live in poverty than their urban counterparts. Now, part of this is a mixing in urban areas of pockets of obviously just deep historical disinvestment from redlining and other historically racist policies. But in urban areas, we've seen a great amount of development and of reinvestment in places where in rural areas, particularly minoritized rural areas, we have seen no such thing. And so these gaps are again widening in rural compared to urban areas. And you can see in children, whether you look at the under 5 or under 18, and working age adults, the smallest gap in seniors, but overall about a 4 percentage point difference in poverty rates between rural and urban areas. We also know that where rurality and poverty intersect, outcomes are worse. I sort of showed you this in a map before, but I think this figure does a nice job of showing it. The orange solid line on the top is the rural high poverty areas. And you can see really that's the group where progress in mortality has stagnated since the mid 80s, when, or I guess early 90s, when that line really started to diverge. Now, that's a combination of things. It's all the factors that I said, in addition to sort of the advent of technologies that has, as was mentioned in the prior presentation, that if you do new things and only make them accessible to a certain group of people, then you actually can create disparities by putting in improvements for one group and not another. And so it's a combination of all the things I said, in addition to, I will acknowledge, access to certain technologies and treatments. So education is another issue that underlies health and hypertension, particularly. Obviously, being health literate in being able to manage your own medical issues, your complex medication regimens, all the thing it takes to treat hypertension, as was so eloquently described in the past presentation, that runs with education. It's not perfectly in tune with education, but it is certainly related to the degree to which people have access to that education. And you can see in metropolitan versus non-metropolitan areas, a lower proportion of folks with a bachelor's degree or higher in the orange, and then a higher proportion of folks with lacking even a high school diploma. And though it's improving in all areas from 2000 to the more recent years, or around 2020, we still see pretty significant gaps between non-metro and metro areas. Food insecurity is another thing that I think historically we've thought about as being, rural areas having farms and sort of food aplenty, and that's just not true. In more recent years, we've seen that food insecurity is more common in non-metropolitan than metropolitan areas. Part of that is actually the availability of social services to be able to support people who are facing risk for food insecurity, and a lot of it obviously goes along with those graphs on poverty that I showed you already. And then finally, there's an emerging rural housing crisis. So obviously there's housing shortages everywhere. We've seen major issues with people who are unhoused, just lacking any sort of shelter even in big cities, as there has been really a strain on resources. But actually homelessness has gone up in rural communities to a greater degree than in urban communities. And so this is an issue, again, where there may be fewer resources. And all of these things come together. You might think, what is the relationship between, housing and hypertension? But if someone doesn't have some place to store their medications, if they don't have some place to get good sleep, if they don't have some place to be sheltered, their rates of hypertension are higher. And there's good epidemiologic data to show that hypertension is, majorly impacted by a host of social risk factors. So let's talk a little bit about some of the structural issues more on the system side. So we know that rural areas also have higher levels of uninsurance than urban ones, and we know that it impacts minoritized groups to a greater extent. So you can see on the left, the percent uninsured, the darker color blue is, I'm a Michigan person, so I'll use blue. The darker color blue represents a higher proportion of uninsured. And you can see Texas, for example, markedly higher uninsured rates than, say, New Mexico right next to it. But again, sort of mirroring some of the patterns I showed you of hypertension and other chronic disease. And on the right, you can see for non-metropolitan and metropolitan that the rates of uninsurance are greater in rural areas among every racial or ethnic group. And that is particularly notable among non-Hispanic, Black, and Hispanic, and the other race group, which is includes people who are American Indian, Alaska Native, Native American, depending on how the survey captures that, as well as people who just choose to answer other. So that is a bit of a tough group to disaggregate, and we should disaggregate when we can. But you can certainly see for Hispanic and non-Hispanic Black really marked differences in insurance coverage. Medicaid expansion, or really the lack thereof, is a major contributor. And so you can see here the most recent state action on Medicaid expansion, and obviously there's a geographic pattern there that you can see in terms of who has expanded and who has not. And to put a little bit of detail on it, so in Missouri, where I'm sitting right now, before expansion, which happened sort of during COVID, you had to have dependent children. So if you didn't have dependent children, you could not qualify at all for Medicaid. You had to make less than $2,400 per year, and you had to have less than $2,000 of assets. Now, there is no scenario in which someone who makes less than $2,400 per year and has less than $2,000 of assets is spending money on healthcare or health insurance. They are desperately trying to find food and shelter. And so really the idea that folks who are struggling to that degree are going to be able to either purchase health insurance or afford healthcare is sort of just beyond the pale. So now, with or without children, individuals qualify up to $20,783 in annual income for an individual, and obviously higher for a family. And I'll say, as a practicing cardiologist, I've seen a massive difference in access to medications for things like hypertension among people who are living in poverty. We know workforce is a major challenge in rural areas. And so here you can see the mental health professional shortage areas on the left, and the primary care health professional shortage areas on the right. And again, they overlap with where we see rural minoritized communities. We also know that access to specialty care is lower in rural areas, and it certainly doesn't require specialty care to manage hypertension, but it can sometimes be helpful to have specialty care to manage hypertension, particularly when you have input from nephrology, endocrinology, cardiology, folks who are used to treating resistant hypertension, for example. And you can see here that rural beneficiaries are the least likely to be able to see specialists when they need it, and that lack of seeing a specialist is associated with mortality. So we found in this study lower mortality among patients who required cardiology care who were able to access it. Now, hospital closures are a pretty interesting thing to study. I could give a whole talk on this and an aside, because I think it's such an interesting question around how can we make sure that people have access to care when the economics of keeping a hospital open just don't make sense in some rural areas. But obviously, hospital closures worsen rural care capacity, and I actually think they probably worsen rural primary care capacity as much as they worsen acute care capacity because of the infrastructure around a hospital. But there's actually been interesting data suggesting that when a low quality hospital closes, the outcomes for acute things actually get better because so many hospitals are really struggling that then people are essentially shunted to a better performing hospital. There is some careful thought that we need to give to access to care in rural areas and not keeping open rural hospitals that simply can't stay open, but instead thinking about ways to guarantee access to certain types of care and get people to places that have adequate volume to deal with complex conditions. So we'll end with some opportunities for change. So I think telehealth is sort of, the easy button, you'd think. And I'd agree that it's promising, but it's really underused despite an increase during the pandemic. So this is some work that we've done looking at telehealth utilization in Medicare. And you can see on the left of the slide, though you can't see because it's too low, but if you could zoom in on that bottom line, you'd see that rural areas used to have the highest rate of telehealth. Now it was super low, but it was the highest. If you look further across on the right, you see that the peak, the spike during COVID, and this is a per population rate of use, actually went much higher among urban individuals. And I think the continued use of telehealth has actually been driven by urban areas. You can see rural remains quite a bit below urban, about half the use of telehealth. People are using telehealth as a convenience factor in urban settings, as opposed to sort of a fundamental access factor in rural settings in many cases. We know that insurance expansion is crucial. So the effects of insurance coverage are well established. I showed you the sort of geographic remainders in terms of Medicaid expansion, and this is really a policy priority. We know that having access to care via having insurance is absolutely crucial to all parts of the healthcare journey. And that includes financial protection. It includes primary care visits, ambulatory care visits, prescription medications, preventive services, physical health, mental health. Giving people insurance does lead to increased utilization. And if anyone ever tries to sell you on that as a bad effect of insurance, don't believe them, because that's how it's supposed to work. We want people to use healthcare if it's the kind of healthcare that will help them control their hypertension. We know that insurance expansion is associated with lower mortality, including infant mortality, and some of that is driven through maternal cardiovascular health and hypertension, as well as cardiovascular disease in older individuals and cancer. And we know that the impacts are largest for racial and ethnic minority communities and in rural areas when access to insurance is expanded. But of course, we also know that infrastructural investment is needed. As I've shown, and as all of you already know, economic opportunity is a major driver of health outcomes. And so if we ignore the disinvestment in rural communities, we'll never make progress. We'll be fighting an uphill battle. We need community-based programs, and the examples that we heard this morning just before I spoke in that wonderful presentation, I think could be adapted to any community based on community needs, right? Communities need resources to deliver them, though, and sort of saying from on high that we have to do better is not helpful. We need actual resource investment in communities where hypertension is prevalent and where hypertension is undertreated. We know that clinicians from rural areas tend to stay in rural areas, and very few urban clinicians go to rural areas. So we need to invest in training programs, and that's community health workers, pharmacists, nurses, all parts of the care pathway. Broadband and satellite data access is actually still a challenge in rural areas. This is more true globally than in the US, but there are areas where there's very little internet access, and that just needs to be fixed if we're going to give people access to any kind of ongoing care. And then finally, stable, consistent, and enhanced funding models for rural hospitals and clinicians. There are current demonstration projects going on. There's a new rural emergency hospital designation. We have to make sure that rural communities can maintain access to care. That may not mean a full-serve hospital, but we need to make sure that it includes the tools for things like hypertension control, diabetes control, to really be able to take care of people before they end up with strokes and heart attacks. So in summary, rural health disparities are large and growing. Hypertension is a key driver and must be central to how we think about implementing these solutions. It's obviously multifactorial and it's not simple. It's standard risk factors, novel risk factors like mental health, as well as, of course, social risk. Healthcare access and quality are challenges, and solutions that I hope we'll get a chance to talk about in the discussion are broad, but include things like telehealth, insurance expansion, and of course, broader infrastructural investment. So with that, I will turn over to the next speaker and look forward to ongoing discussion. Thank you so much.
Thank you so much, Karen. I have so many questions for you, and that was such an amazing presentation. And I can't wait for the panel discussion with Janet. And for anybody out there who has questions themselves, feel free to type it in the chat box. We will have that moderated discussion after Dana's presentation. So thank you so much. So with that, I am going to welcome Dana Gelb Safran up to the virtual stage. She is the president and CEO at the National Quality Forum and Chief Scientific Officer at the Joint Commission. So Dana, the floor is yours, and you should be able to advance the slides on your end.
Thank you, Jenny. One question, I don't know how to advance them from my end. I haven't
should-
done that before.
You should just use the arrow. You might be able, if you use the arrow, it should go. The arrow in your
Oh, let me just test. Oh yeah, look at that. Okay, fantastic. Thank you, Jenny. And good afternoon, everyone. For those on the East Coast, I am joining you from Chicago today, and unfortunately, only got to hear the tail end of Dr. Joynt Maddox's presentation. And so it was really, really important information she was sharing, and I only wish I could have heard the rest of it in the earlier segments of the day today. And my sincere thanks to Janet Wright and her team for inviting me to be part of the summit. The goals that I have for my 20 minutes with you before we have our panel discussion that Janet will facilitate is to talk a bit about the role of payment and payment incentives for improving quality and outcomes, including quality and outcomes, of course, for hypertension. And I will spend the first part of the time speaking about a payment model that I personally had a very close involvement with developing and then managing, and some of the really exciting and important population health benefits, including for hypertension control, that we saw through the accountability in that program. And then I'll, in the final part, talk a little bit about advances that are needed in the quality measures that we have available to us in order to go further in achieving the population health goals that I think unite all of us who are here today. So let me go ahead and advance to the next slide. So the payment model that I was referencing a moment ago is called the Alternative Quality Contract, or AQC. And the AQC was designed in 2007 at Blue Cross Blue Shield, Massachusetts, and launched in 2009. It continues on today. And it really was an important catalyst for payment reform in the US, because it was the first payment model that brought together accountability for total cost of care, so a global budget, and a broad and robust set of quality outcome and patient experience measures. That pairing of quality and outcomes and experience with cost accountability was novel at the time. I know today it is not, and it is not an overstatement to say that the AQC really played a role in the advances in models like this that now are so common with CMS programs and with private sector payers and in Medicaid as well. And at the time, there were 5 things about the AQC that were differentiated from Blue Cross's traditional payment models. One of those was that a provider who came into the model, and it was always voluntary, it remains voluntary, but over 90% of the Blue Cross Massachusetts network is in this model voluntarily. The first differentiator is a provider who comes into the model agrees to be accountable for end-to-end patient care for an entire population. So everything from prenatal care to end-of-life care and everything in between, that provider organization is agreeing to be accountable for all of that for their patient population. The second differentiator is that the contracts are long-term, 5 years. You can see that in the visual here. compared with typical contracts at the time, which were sometimes 1, 2, or at most 3 years. A third differentiator is that providers had accountability for a population-based global budget. And that's what's signified by the dotted line going across the page. Providers had the opportunity to earn shared savings if they underspent that population-based budget in a year, or a shared deficit if they overspent that budget. Fourth, inflation on that budget over the 5-year period was defined in advance before the contract started and was designed to come down over time so that by the end of the contract, it would be roughly the same as general inflation and not the 3-4 times inflation rates that we had been seeing for many years running. Finally, and importantly to our conversation today, the model had a very broad set of quality outcome and patient experience measures on which providers in the contract had the opportunity to earn significant quality-based bonuses. We'll talk a little bit more about that. But when I say significant, I will say there had been and still remains nothing like it, the AQC, in terms of the generosity of the quality earnings potential and the quality bonuses that actually got achieved. And I do think that in contrast to many alternative payment models since that time and in place today, that differentiation of the dollars on the table for quality is part of why we saw the very significant quality improvements that we saw. So let me, this is just to give you a view of what that quality measure set looked like. There were, as you can see, measures in the ambulatory and hospital space because the measure did have, the contract did have accountability for that whole continuum. And for each of those settings, you can see we had a set of process measures, outcome measures, and patient experience measures. But what I would draw your attention to is in the ambulatory space, the outcome measures, which were triple weighted. Now, at the time, it was unprecedented for a payer to ask providers to become accountable for outcomes of care. Performance-based payment was still relatively new at the time, but to the extent it existed, it was based almost exclusively on measures of process. And to be honest, I was, in my role at Blue Cross Mass, newly out of an academic setting and thought that there was really going to be an enormous amount of pushback at putting forward these ambulatory outcome measures. But instead, the early adopters of the AQC, who were visionary themselves in what a new payment model could help them achieve for their patients, said, these measures should count more. They're the most important measures in your set. If we could get to your highest levels of performance on these measures, we would have achieved something very important for population health. Don't you agree? And we said, of course. And they said, so you should make these count more. So you can see these were triple weighted. So let me show you what happened. And then it does include blood pressure control for those with hypertension. It also included blood pressure controls for those with diabetes and cardiovascular disease. So one of the reasons that the AQC model has been so influential is we had the incredible good fortune of having a team from Harvard Medical School who were studying the results of what we were achieving while we were doing it and publishing on an annual basis, sometimes in New England Journal, sometimes in Health Affairs, JAMA, what the results were, both the cost results and the quality results. And so what you see here, the blue line is the Blue Cross Massachusetts AQC cohort that started in 2009. The pink or purple or whatever color that is, magenta line is the New England trends. And then the teal colored line is the national trends. On the left are process measures, adult preventive care process measures. On the right are the hypertension and diabetes control measures. So what do you notice? Well, you notice that when we launched the AQC in 2009, the providers in our network were performing at the same level as the rest of New England, not any better, and that New England was a little bit better than the nation. And then you notice very quickly, providers in our network start to take off in their performance on hypertension and diabetes, including blood pressure control measures. Now, why that's so important is this particular slide doesn't go back that far in time, but what I can tell you is not only back to 2007, but back as far as we could see, these measures of blood pressure control, hemoglobin A1C control, cholesterol control had been flatlined for a long, long time. And there was nothing that we or others were doing that were creating improvements. And when you had roughly only 2/3 of the population with these chronic illnesses under good control, most of you who have a clinical background know that is a recipe for truly bad outcomes in the years ahead. And so the ability to suddenly jumpstart and get to levels above 80% of patients with hypertension or diabetes having their blood pressure under good control, their blood sugar under good control, was really one of the most important accomplishments that we saw of the AQC. The additional thing that I would highlight is we also saw a narrowing of long-standing disparities in care. So this was from another of the Harvard Medical School team's articles. This one was in Health Affairs in 2017. And I would focus your attention first on the yellow versus the green line. So the yellow line are the populations whose providers were in the AQC, and they as patients had relatively high socioeconomic status. The green are patients whose providers were in the AQC, and they had relatively lower socioeconomic status. So notice that in 2007, before the AQC began, the gap between the yellow and the green is sizable. And that over time, with the AQC having launched in 2009, that gap narrows. As you all know, we have a mountain of literature that show us disparities of care, but very few interventions that we have found that actually address those disparities, not just find them, but address them and narrow the gap. And so this was really one of the proudest accomplishments of the AQC. You can also see that outside of the AQC, in the rest of our network, for those with higher SES in blue, lower SES in red, no such narrowing was occurring. So that's the power that I wanted to share of payment models. Just quickly, audiences always want to know, how did these changes happen? And I'd like to summarize that really I saw our provider network innovating in these 4 important ways. They were implementing new staffing models, including bringing pharmacists onto the team, bringing behavioral health providers into primary care, and having staffing models that had clinicians seeing patients in the community outside of the clinical practice setting. And all of this meant very different approaches to patient engagement. You can't get to those improved outcomes on blood pressure control and the other outcomes we talked about without engaging your patients in new ways, because fundamentally we know that they require patients to be taking their medicines, they require patients to be eating differently, exercising differently, managing stress and life differently. The other 2 important areas of innovation had to do with their uses of data and health information technology and their referral relationships and the ways that they were using the rest of our network. So I'm going to spend the last moment of my time. How am I doing, Janet? Do I have 4 minutes or so? Is that right?
You have about 4 minutes. Yep.
Okay, that's what I thought. Great, thank you. So I'm going to spend the rest of my time just to talk a little bit about, from then until now, we really haven't seen the evolution of the nation's portfolio of quality measures to become more outcome oriented. And that is really what is needed for value-based payment ultimately to be successful. Value-based payment seeks to address population health. So we want health outcome measures like the ones we've been talking about, and not, hundreds of process measures that feel burdensome and frankly micromanaging. And yet, there hasn't been any real significant progress in delivering on the new outcome measures that are needed for value-based payment and population health. These are some from NQF, the voices from the field that we heard just a few months ago in this year, about the distress that the field feels about the quality measures that we have today. To address this, back in 2002, when I was early in my tenure at NQF, I brought forward a new initiative that continues today called Aligned Innovation. And Aligned Innovation is a coalition-based model to accelerate development of measures that are outcome-oriented and that fill high priority gaps that payers, purchasers, providers, and patients all agree are needed to deliver on improved population health. So these are the coalition members. You can see, payers and purchasers, public and private sector from across the country. And this is another key part of Aligned Innovation, which is our multi-stakeholder advisory council that really wraps around the process. These are ultimate end users and enablers of the measures, organizations and federal agencies that we want to have wanting these measures for their own use when they are finished in their development. And so Aligned Innovation is differentiated in several important ways. Oops, let me just go back for a sec. From traditional measure development, one of which is this prospective alignment, right? So that we don't have everybody developing different measures and no coordination. We align on what's the measure that we need the most, and let's all agree to get it developed. Let's do so in a way that engages patients and clinicians who care for them to be sure we know what are the outcomes that matter to them, and those become the measure concepts that we develop. We engage a generalizable group of providers from across the country to be sure we're getting broad input to understand what are the operational and practical and clinical objections to a measure so that we solve for those before it's completed. And we do it all in a 2-year time frame. And we are about to complete the first 2-year cycle of measure development and put forward the first measures. So the 2 areas that were prioritized back in October of 2022 were maternal health outcome measures and behavioral health outcome measures. And very relevant to this group, maternal hypertension control was identified by patients and clinicians as one of the most high lever opportunities to improve maternal outcomes. And so we will be completing in the first quarter of next year a measure that addresses maternal hypertension control. That has been a key gap. This audience probably knows that, but if you don't, I'll just conclude my remarks by saying our existing measures of hypertension control, the ones I was talking about that were so successful in the AQC, exclude people who are pregnant. And they do that because the thresholds for what is considered good control are not only different during pregnancy, but change over the course of pregnancy, or change based on whether you had hypertension before pregnancy or developed it during pregnancy. So it's a complex measure, but we now will be putting forward a measure of hypertension control during pregnancy and postpartum, which fills, such an important outcome measure gap in our country's portfolio of measures. So I believe that is all I had for you. It is. And so let me conclude it there and really look forward to our panel discussion. Thank you.
Thank you so much, Dana. And I'm going to ask you to stay on the virtual stage, nothing you need to do. But welcome back, Dr. Joynt Maddox on the stage, and introduce, for the one person who may not know who she is, Dr. Janet Wright, who is the Director of the Division for Heart Disease and Stroke Prevention at the CDC, who will be leading and moderating our discussion. So Janet and others, the floor is yours.
Thanks so much, Jenny. And really, I've been so absorbed in these two wonderful presentations that I almost forgot about the panel part. But I want to thank everyone who's joined us today in the roundtable. And I think we've heard from all three speakers something that the roundtable is living into, and that it does take multiple sectors, and all of us need to be involved from the beginning in the solutions for this hypertension and equity problem in the country. So thank you to our speakers. And just a reminder that Dr. Joseph, our first presenter, had an obligation and is unable to join the panel, but I did quiz him about a few things, and we'll share his comments. So, you know, I'm going to use first names. Hope you guys are okay with that. Great. So Karen and Dana, I feel like you two might have questions for each other. And Karen, I know that you have spent a lot of time in the payment space. And so I might just ask, Dana, I know you didn't get to hear all of Karen's presentation, but why don't I give you two the right of asking questions of each other before I pose a few, and then we'll take some from our all our attendees today.
Oh, gosh. I guess one thing that I'm curious, maybe if Dana, you can comment on is sort of multi-payer approaches to this. So obviously the AQC was phenomenal. Can other people do the same thing? Are people using the same measures? Like, how can we get more folks involved in that space?
Yeah, that's such an important question, Karen. And you know, just later this week on Thursday, the Healthcare Payment Learning and Action Network, the LAN, is having its annual summit. And the whole orientation of the LAN is multi-payer alignment, because it's seen that the lack of alignment is one of the biggest impediments, both to adoption of alternative payment models and to their success. Because you know better than most, Karen, from being in the clinical setting, that if you're dealing with, you know, just different incentives, different measures, and from every payer that you're contracted with, it all just comes across as noise. And so harmonizing, you know, the measure sets that are used in the models is a very important goal. I would say it's been a goal for 8 years, maybe going on 10. And we haven't made a lot of progress, in my opinion. It is part of why I am excited with Aligned Innovation that we've introduced this new concept of prospective alignment. Let's get aligned on the measures that we all agree we need, and then let's develop them in a consensus process. And when that is done, let's use them as is. And by the way, I didn't mention that all the stakeholders agree they'll retire 2 measures for any new measures that are added through Aligned Innovation to really focus on burden reduction. But anyway, I do think the multi-payer alignment is really an important step. And I know that's being worked on in a lot of places. The LAN has really made it an active conversation for years now. And there are 4 states where CMS and CMMI are working with the LAN on multi-payer adoption of payment models and measure sets, and the state transformation collaboratives, those are called STCs. And by the way, I think every one of the 4 is addressing maternal health issues as part of their focus. So I hope that answers your question. I'll ask one of you, Karen. So, you know, as I said, I didn't have the benefit of hearing your full set of remarks, but I tuned in when you were talking about rural communities and the particular challenges there. And of course, there has been an ongoing debate about how you address differences in the socioeconomic status of populations served by different providers. I tipped my hand a little bit by showing the slide I did, that I think that the most effective way to address disparities is to invest in those in narrowing disparities by paying differentially to providers who care for a lower SES population, and or providing upfront resources, understanding it will take something different to get to a given level of outcomes. But I'm curious to hear from your perspective in the communities that you know well, and from your own clinical work, How do you think about that?
Yeah, it's a good question. And it's tricky because you don't want to accept poor performance in groups that are facing more barriers and just say, yep, it's fine that no one has their blood pressure controlled, because they happen to also be struggling with being able to afford their medications. At the same token, if you sort of judge the practices that are caring for those folks and say, we're going to take your money away if you don't hit, X achievement, realistically speaking, there's only so much that a clinic can do when you're not going to get to perfect blood pressure control, especially if you're taking care of people where they are facing a lot of barriers. I think there's both a measurement piece and a payment piece. On the measurement piece, and maybe you can take this back to your measurement folks, I'd love for us to think a little bit about how to encourage clinics to get focused on and rewarded for bringing people's blood pressure down. We have people in our emergency room every day whose systolic blood pressure is 240. I can have them on 5 drugs. We're not getting to control. We do it. I work on a cardiology service. We get the resistant hypertension, the hypertensive emergency. It does not matter what you put some people on, especially if they have renal insufficiency and other issues with, kidney disease. You are not going to get to control. I have done a world more good of bringing that person from 240 to 160 than finding my suburban patient who needs 1 drug therapy, giving him a cup of tea and remeasuring his blood pressure to get it under 130. But we look at everything as this binary. Do you get people to control or do you not? And it's really like, are you in there working? Are you doing the work? And that is the nuance of sort of where this stuff lives. And historically, that was a pretty unovercomable measurement challenge, but I'm not sure it needs to be actually with current data. So I'd like us to think about ways to think with some nuance about, and Million Hearts did this, the proportion of folks under control, the proportion of, under certain levels, again, paying more for folks who have more resistant hypertension, or for a group of people where the barriers are higher. And this whole, we'll pay you only if you get X number of people under a level that's just tough, I don't think actually does us favors for equity.
Yeah, I couldn't agree more, to be honest. And I, in a lot of ways, we didn't talk about the behavioral economics of the AQC financial incentives, but what you're saying reminds me in that what we did was to get rid of the cliffs, as we called it, where like you either make the measure or you don't, by having performance targets that were continuous from what we gate 1 to gate 5. And for every single increment of improvement across that continuum, you are getting rewarded. And so what you're pointing to is that in certain measures, including blood pressure control, the measure itself is a cliff. And so it's very discouraging if you can't even get close, like the example that you gave. We don't want to create an incentive that you just triage the patient, because there's no hope of getting this patient to target, while your suburban patient you do. So, I have heard before this idea of, can we have a measure that addresses progress in getting to control? But I love the way you've positioned it, and I will take it back to the team and talk about how we could accomplish something like that.
Well, I do want to take some questions from the crowd, but before we do, what I've heard today and heard from other sources and observed is that this is hard work. Improving hypertension control and equity in hypertension is hard. It takes, I've been saying sustained effort, but I like what Dr. Joseph said earlier today about persistent effort. And I think both of you have been persistent in your efforts. You've both told that story today. The other thing is that it takes multiple folks all engaged from the beginning, very much the model that you've shown us in Aligned Innovation, Dana. But what I do have in the middle of the night I fret and I worry, are we not doing the right things? Is that why we seem stuck? Because we haven't yet, we say we know what works, but do we know what works? Or do we know the right things, but we're not getting to the right places? Or sufficient number of right places to move the national needle, or is the problem that we just haven't been doing it long enough? I'm no longer naive that my Million Hearts experience, we couldn't get to 1 million events in 5 years, and some people thought that was folly from the get-go. So where, or is there something else? Talk to us about, are we on the right track? But we need to do more scale and spread. Where are the opportunities? Because the roundtable is all about solutions and opportunities.
Karen,
I'm
would you like
Yeah,
to?
I'm glad to go. I have plenty of thoughts. I mean, the easy answer, the cop-out answer to your question, Janet, is yes.
All, yes.
All of the above, but I won't stop there. Actually think that we have made this needlessly complex in some cases, and we're not engaging the right people in the conversations. And I will say things are much, much better now than they were 10 years ago. And the fact that we have conversations about population health where people at like health systems are talking about population health is new and different and wonderful. And that, so don't hear me as saying there has not been progress, because I think there's actually been like philosophical progress towards thinking about population health. Where we're not there yet is that the system is still requiring people to come into an office once every 12 months to sit down, to get their blood pressure checked, to have a doctor say that they have to have a different medicine. That's bonkers. This is hypertension. This is not like gamma knife brain surgery. And you don't need to be in a doctor's office. You don't need to be in an operating room. You need to have a blood pressure cuff. This can be in your house. You can have a community health worker and they'll do more good for you in working on your blood pressure than I will. It's not that there's some sort of trade-off in quality of management by moving things to pharmacists and community. They're better at it than having you come into the office with all the technology around you and get it done, right? So I think the philosophical shift has started. I think the system has not yet shifted, and that's payment, and it's complex and it's hard, and change is hard. But I do think we are philosophically starting to agree that in general, healthcare needs to move in that direction for hypertension, diabetes, obesity, those sorts of chronic issues.
Yeah. So I'll just layer on top of that. I think that's 100% correct. A colleague of mine used to call it the tyranny of the office visit, right? That, we have to evolve beyond that. The thing that I would add onto that is I think that part of what we haven't actually achieved and have mostly given lip service to is care that is truly patient-centered. And the reason I say that in this context, Janet, is the answer to, why we haven't gotten farther, et cetera, is that what the barriers are differ person by person by person. And it is some of what I saw in the AQC that had me understand how these organizations were achieving the results they were achieving, especially with respect to outcomes, which rely on patient action, right? Was that they came to understand that they couldn't achieve those outcomes if they thought only about the patient inside the four walls of their clinical setting. They had to think about, where does this person live? What access and affordability do they have to the foods they need to be eating? And motivation do they have? We have in hypertension, an illness that we know is asymptomatic, and medicines that make people feel sick. So, there's so many reasons that this is a really hard one. But I think until we actually get to individualizing care in some of the ways that we saw contributing to the success that I showed you on the screen, we are stuck. So that's how I would answer your question.
I had one more thing too. I think we have a little bit of a marketing problem, and I'm not a marketing person. But so I'm take this with a grain of salt. But the idea that a lot of our federal health policy efforts have been around cost containment, I find incredibly problematic. Because when we think about payment models, if we want people to want to participate in them with their health, and if we want clinicians to participate, they have to be about making people better. It can't be about saving money. Now, we can know that it saves money for people not to have strokes, but actually the more important thing is that that person doesn't have a stroke. And I would love to see Medicare, Medicaid payers keep their cost containment thoughts to themselves and instead talk about getting clinicians and patients engaged in these spaces. Because if you want to know what patients need to control their high blood pressure, you should ask them. And what Dr. Joseph said in his conversation about getting patients to that aha moment of, I can control this. I understand the medicines. I am part of this. This is positive. This is for me, I think is really hard when we spend a lot of time talking about saving healthcare costs, and that's why we're doing all these payment programs. I think we need to rebrand a little bit around being healthy collectively and really like let patients be at the middle of that conversation. They know, they get it. It's their health.
I would love to follow that thread. I'd love to hear from you all where you think the opportunities are in the months and years ahead, but I don't want to take the spot here. I know we've gotten some questions and I want to make sure we get those to you. I'm seeing one from Eleni Tsigas about how payment models could overlay with bundled payments for obstetric care. As you know, the OB care is a bundle because we're often asking our OB providers to operate as a PCP for a while.
Yeah, I'll be glad to address that one to say, I am unabashedly biased toward models that are global. That is, they say that, like I described, from end to end, from prenatal care to end of life care, everything is the accountability of the organization that's providing care, and that bundles have a very valuable place sitting underneath those global budget models. And part of my reasoning for thinking that is that I think we get ourselves into trouble when we are doing bundles and focusing just on a particular illness or just on a particular procedure, because it rows in the opposite direction of where I think probably everybody at this table today is trying to get, which is a more whole person oriented approach to care. But bundles can play a very valuable role sitting within global budget contracts. And so that's how I would answer Eleni's question.
We did some work here, and it was led by Kate Lindley, who's a cardiologist who's now at Vanderbilt, but was here when she was doing this. And she developed a clinic for postpartum hypertension. And the sell was that it was going to be advantageous for the bundle, actually, because of the spend on a small number of patients who are readmitted with eclampsia, preeclampsia, just straight up hypertension that's unmasked. But the intervention is so cheap that the sell was actually that within a bundle, you are better off doing some sort of postpartum blood pressure monitoring specifically. We have some clinical trials going that are, it's actually very interesting in both Nigeria and St. Louis. So Nigeria has some of the most adverse maternal outcomes in the world. St. Louis happens to have some of the worst in the country. And there's a Parents as Teachers program that is operating in both places, doing fairly straightforward postpartum hypertension monitoring. And it is easier to sell under the auspices of a bundle because people have some accountability for that. The bundle has to be long enough that you want to prevent complications postpartum. It can't just include a delivery, but if it goes beyond that, it's actually a pretty good way to get hypertension included.
And if I could just mention one other thing, which is pregnancy is one of the few instances where a bundled model as a standalone can make sense, because there's no ambiguity about when the episode began and that the episode is needed, right? With other illnesses or procedures, there is that ambiguity. And so you basically have what I would call the fee for bundles problem, right? It's not really any different from the volume-based incentives that you have in fee for service. But in pregnancy, it's a very defined and unambiguous episode. So it is one of the few instances where I think a standalone bundle can be very useful. And, Karen just described some of the measures within it can really make a big difference in outcomes.
I think we could go on for quite some time here. I think, Jenny, let me double
There's
check.
one more question, actually, a question that was embedded in a comment. So Hattie mentioned that they've had great success with MI reduction in their NIH pilot, driving 3 metrics, LDL 100, BP 140/90, and A1C 8. Is there progress in bringing back the LDL 100 measure?
I don't know for sure, so I wouldn't want to say definitively, but if there is progress, it's not progress that I've heard.
Thank you.
Karen, what about you?
I mean, my personal opinion as a cardiologist is that 100 is too high. But no, I think the general guidelines have sort of moved away from that, unfortunately. I agree, though. So the simplicity is really beautiful. And, you know, maybe we need to go to like a yes, no on statin or something like that. But yeah, I also bemoan the loss of simple numbers.
Well, instead of the tyranny of the office visit, we have the tyranny of the clock. So let me thank you two so much for your presentations today and thoughtfulness in addressing questions that came up. We would like to continue to engage you. I made a joke earlier that there's a one-way door with the roundtable. Now you're part of the roundtable. And we will be back in touch. Thank you so much.
Thank you both so much. This has been amazing. And again, we'll look forward to our continued conversations. With that, I'm going to pass it over to Tom King, who is the Policy and Partnerships Team Lead within the CDC's Division for Heart Disease and Stroke Prevention, to announce our annual Sal Lucido Hypertension Hero Award awardees. Tom, the floor is yours.
Thanks, Jenny. As Jenny said, I'm here to present the Sal Lucido Hypertension Hero Award. We've had this award with the Roundtable for the last couple of years, but going forward, we're renaming it after our dear departed friend, Sal Lucido, who passed away a year ago yesterday. Those of us who knew Sal miss his unwavering support of the Roundtable and Boston sports, his great sense of humor, kind of acerbic, but a lot of fun, and his loyalty to his friends and colleagues. But we're not necessarily renaming it just because of what kind of great guy Sal was, but because of his contributions to the Roundtable. He was an exceptional and dedicated public servant, but also the father of the Roundtable. Without his leadership and his drive, the Roundtable wouldn't exist and we wouldn't be here today. Sal had a long career at CDC, working in policy and partnerships all over the agency for over almost 30 years, I want to say. In 2016, he took over as the Associate Director for Policy, External Relations, and Communications within the Division for Heart Disease and Stroke Prevention, and he served in that capacity until his death last year. In 2019, our division launched and held 2 very large and successful partner meetings focused on improving collaboration on hypertension control efforts, but that wasn't enough for Sal. He didn't want to rest on our laurels. He didn't want to stop there and wanted to use the momentum from those meetings to build a permanent multi-sector coalition for improving hypertension control. And that became the Roundtable. He proposed the creation of the Roundtable modeled on the American Cancer Society's very successful colorectal cancer Roundtable. And so he got to work. He worked tirelessly to launch and sustain the Roundtable. He engaged the partners and brought many of the original members to the Roundtable. He established the Roundtable's governance structure and drafted the initial bylaws for the Roundtable. He secured the CDC funding that supports the Roundtable to this day. He worked closely with the original co-chairs, Dr. Eduardo Sanchez from the AHA and John Clymer from the National Forum, to keep the Roundtable alive during the COVID-19 pandemic when everybody was focused on everything else but hypertension, and that was no small feat. We would not be here today without Sal's vision and his tireless work to make the Roundtable a success. And because of that, in his contributions to the Roundtable and his standout character, we're going to honor Sal at the same time that we honor those who are making a huge difference in the battle against hypertension. And so I'd like to then move towards presenting our Hypertension Hero Awards to 3 amazing recipients. Our first recipient is the enhanced community health worker support for the 4th trimester and beyond for postpartum women with hypertensive disorders of pregnancy project at Emory University. It's a mouthful, but it's a really great project. This is a demonstration program at Grady Memorial Hospital in Atlanta in partnership with Emory University that focuses on the postpartum management and support of women with hypertensive disorders of pregnancy. Make sure I get this right. The program uses a multidisciplinary team-based approach, including incorporating community health workers to provide tailored and comprehensive patient-centered care to improving outcomes for mothers in the 12 months after delivery. Accepting this award on behalf of Emory University at Grady is Dr. Modele Oguni, our former co-chair of the Roundtable. Congratulations. Our second recipient is the Rhode Island Free Clinic. The Rhode Island Free Clinic exemplifies what it means to be a hypertension hero through its holistic, inclusive, and patient-centered approach to healthcare. By providing free, high-quality care and engaging in meaningful partnerships aimed at improving cardiovascular health, the Rhode Island Free Clinic not only addresses the immediate health needs of its patients, but also contributes to the broader goal of community health improvement. Its efforts in education, multidisciplinary care, and quality improvement make it a model organization in the fight against hypertension. Accepting this award on behalf of the Rhode Island Free Clinic is their CEO, Jessica Eagles. We want to spotlight. And finally, our third and final recipient is the National Forum for Heart Disease and Stroke Prevention for their Move with the Mayor initiative. Move with the Mayor encourages and supports mayors in implementing evidence-based policies and programs and infrastructure changes that promote physical activity, reduce stress and anxiety and depression, and foster smoke-free living, all of which help prevent and reduce hypertension. The initiative has involved over 60 mayors across the United States, focusing on underrepresented and rural communities with high hypertension rates. Move with the Mayor has resulted in policy and environmental changes that enable people to prevent and control their hypertension, and has proven to be effective at reducing hypertension and improving healthy behaviors. It represents the kind of cross-sector collaboration that the National Hypertension Control Roundtable stands for. And accepting this award on behalf of the National Forum is its Executive Director, John Clymer. And congrats to National Forum and to all 3 of our hypertension heroes this year. We thank you for your incredible, incredible work and for the difference that you're making in hypertension control. And we hope that so all the people watching on this broadcast, that you think of other exemplars that we can highlight next year and in the future as potential hypertension heroes going forward. And I'll pass it back to Jenny.
Thank you, Tom, for that. And congratulations to all of our awardees and to the National Forum. Apologies. I saw that your program got cut off on this slide, so apologies for that. We will be sending out information about all 3 awardees in a follow-up email with the recorded link for this summit sometime after today. In addition, we have a page dedicated to all of our awardees, and including the background that Tom shared around Sal. So that'll be on our website, so more to come with that. But again, congratulations to everyone. So I'm going to see if Janet, Jaime, or Yvonne have any last words, but I just want to, again, thank all of the amazing speakers today. It was such an amazing conversation. I can't wait to continue our dialogue. Thank you to everyone who attended today's summit. Know that if you have any ideas for fireside chats, or you would like to present or add those resources in our newsletters, I invite you to reach out to me. My door is always open. I love talking with individuals and learning about all the amazing work that you are doing on the ground every day to control hypertension in the communities that you serve. So I thank you for all of your hard work. So Janet, Jaime, and Yvonne, any last words from our fearless leaders at the Roundtable?
Beyond thanking Dr. Murillo for his service and Dr. Commodore Mincer for her ongoing service, I have nothing else to say. Thanks so much.
Well, with that, I will give 10 minutes back to everyone's day. I hope you all have a wonderful afternoon, and I look forward to continuing to work with you over the next year. So thank you, everyone. Have a great day.